Good morning, everyone. Today's first case is a 51 years old man with a medical history of hypertension, poorly controlled diabetes, dyslipidemia, and former smoker. He suffered an acute cerebrovascular accident in April 2023, and he was admitted due to exceptional angina. An echocardiogram showed a normal left ventricular ejection fraction, but revealed inferior akinesia. Analysis results indicate a low-density lipoprotein level of 200 and a blood glucose level of 500. The treatment plan includes dual antiplatelet therapy, rosuvastatin, and ezetimibe. A diagnostic coronary angiography was performed, revealed significant stenosis in all 4 coronary vessels with distal disease, including a chronic occlusion of the circumflex artery. Therefore, a decision was made to proceed with percutaneous coronary revascularization. The patient was enrolled in the Multivessel talent study with randomized patients to receive either ultrasyn supraflex cruise or synergy stent guide intracoronary imaging for multivessel disease based on angiography derived QRF. Today, the plan is to perform a multivessel percutaneous coronary revascularization guided by intracoronary imaging.
Jordan Borja?
Okay.
Okay, so I'm going to explain you, give me 1 second only to retrieve this balloon. I'm going to explain you the setup and the things we have done till now. Okay, you have the balloon. So these are the angios of today. This is a quite difficult to decide case, as Borja explained you, because it's a very young patient with risk factors and this multivessel disease. The right coronary artery is going to be deferred to other procedure, and we are going to treat the left coronary artery. As you see, there is a chronic total occlusion or subocclusion of the circ. That it seems to be a small vessel. We don't know because probably it has a codominance between the right and the circ. And we are focusing today in the intermediate branch and also the LAD. This is the caudal projection in which you can see 2 lesions, 2 focal lesions in the intermediate branch at the ostium and more severe in the intermediate portion. And also, this is the LAD that is quite developed and diffusely diseased. He has a clear severe lesion at the mid, focal lesion at the mid segment, and also moderate, angiographically moderate lesions at the proximal part and also the distal part. Interestingly, we have crossed a wire to the intermediate branch and to the LAD, and the patient developed some vasospasm with ST elevation, anterior ST elevation, because of the vasospasm of the LAD. And after administering nitroglycerin, we have performed an IVUS. Borja, can you show the IVUS, please? Borja, can you show the IVUS?
Okay.
The first one.
First one. 1 second.
That'll play. So you are seeing the pullback from the distal LAD. This is the healthy segment. You're going to see right now the focal lesion. Probably this is a bridge. You can see the eyebrow sign, and here is the severe lesion. You can see the plaque there, and the distal reference diameter is 2.5. This is the lesion. As you are seeing, some calcification, not severe. And the proximal part, the proximal landing zone probably is 3 millimeters in diameter. It's quite healthy. And the proximal part that was indeed without nitroglycerin, you are going to see a diffuse disease with a minimal lumen area of 4.5 more or less, but taking into account the vasospasm of the patient. You are seeing here the diffuse disease, some calcification, probably is a mixed plaque, some branches arising from the bottom of the image, and we are reaching the proximal LAD. And now, after completing the pullback, Borja is going to show you the before bookmark, in which he has measured the luminal area. This is the bifurcation, the carina, and the left main that is more healthy than the LED. Okay, stop and show the before B4, proximal. Vale. And this is the measurement of the area of the proximal ostial LED, 4.5 more or less. It depends on the frame, but with vasospasm. The vessel has increased a lot after nitroglycerin. So we have decided to treat the critical lesion at the mid part and be conservative at the proximal part, because if we treat it, that it could be done, we probably need to treat also the left main, jailing the circ and the intermedius branch. And probably it is not needed today. So the setup is, I forgot to explain you, a radial approach 6 French with an XB 3.5 guiding catheter and 2 cyan blue wires in the LAD and also in the intermedius branch. This patient has been included in the multivessel talent trial that Borja had explained you, comparing the synergy against the supraflex screw, this ultra thin stent that we are using more and more in our country. And all the patients should be treated with a double antibiotic treatment with novel drugs, with parasugar and aspirin. And also all the implantation should be optimized with imaging. So we have, this is the pre-dilatation with quite good expansion of the balloon, with some dissection after that, if you are seeing the angio. Look the spasm at the distal part and also in the proximal every time you do anything. This is the stent that is, in this case, the patient was randomized to the synergy arm. So this is a 2.5 by 28, choose, es 28 el stent? By 20 something? Sí, 28. And you can see this is a nice expansion, but after doing the IVUS, Borja, can you show the second pullback of the IVUS? Okay, play. You can see that the distal part of the stent is quite good, no dissection, good expansion, well opposed. But at the mid part of the stent, probably there is some under expansion of the stent. Probably a little bit more proximal there. The area is not bad, but probably it's a little bit underexpanded. So we have post-dilated it with a 3O balloon. We have, we did a pre-dilatation before the IVUS at the proximal part of the stent, and after the IVUS we have pre-dilated another time in the mid part, in the underexpanded part. This is the dilatation with the 3O. A little under expansion, but I think it's reasonable. And this is the result now. I think we are doing another IVUS after the post-dilatation, no? The third one, because we have done only... después de la segunda post-dilatación no hemos hecho IVUS, ¿no? Pues dámelo, porfa. We are doing the third IVUS after the post-dilatation just to check the final result of the stent. And we are moving to the intermedius branch. Is there any question from the audience, Borja? No. Okay, so this is a very interesting trial we are very involved in. Because we are always thinking which is the best stent. All of them are quite good. All the platforms we use now are quite good. And some colleagues think that probably the ultra-thin platforms are the best one in every case. And probably they have more flexibility, more deliverability, but probably a little bit less radial strength and a problem of visibility probably, but they are quite good in almost every scenario. And also the synergy stent that you know they have a lot of data and we use it a lot with very good results. So the very good, the interesting point of this trial is that we need to optimize everything with imaging, and it's based on physiology, because we are doing this non-invasive physiology before the ¿me dais a live, porfa? Borja, live, arriba. Ahí. Okay. I'm going to advance a little bit. There, and pull back. So this is a bridge. You can see this image, probably is a bridge, and this is the stent. We are going to see some under expansion, but I think that the result is going to be better than before. Probably this was the area of under expansion near here. It's quite better than before. This is the worst part. Okay, but I think the area is quite good. We can measure afterwards the MSA. Okay. Borja, can you measure the MSA donde esté más estrecho por ahí? Ahí. No, con área, con área. Down? It's near 4.5, 5, it depends. I think that taking into account the safety and the result is okay, because we are not going to post-dilate with a bigger balloon, and this is a reasonable result near 5 millimeters square. So we are moving to the intermedius branch. The patient is okay without ST elevation that he developed before with the vasospasm of the artery. So probably he has a mixed disease with vasospasm and also an evident epicardial disease. Okay, let's go with the IVUS here. So let's review the image of the intermedius branch. Here is the image. We are going to work in the caudal projection. Okay, we are here. So IVUS. Borja, we are doing another IVUS live, and you can mark with the intermedius branch to differentiate them. Thank you. Okay. Voy. Thank you. Okay, let's go. No question, right, Borja?
Hay un problema con el chat.
Another possible question is if the patient could be a good candidate for CABG, but in this case, the distal LAD is quite diseased. Also, the right coronary artery, the good vessel for CABG could be the intermedius branch, but only for this vessel, I think it's more reasonable to go for a PCI, and you always have time to put a graft in the distal LAD. Okay, this is the pullback from the intermedius branch. This is not a very big vessel. This is the focal lesion probably there. It's hugging the catheter, probably is quite severe there. Healthy here, and it's important to see the ostium. Okay, this is the ostium, and we are in the left main. Okay, stop. So Borja, we need to analyze the similar than the lady, the distal reference diameter, because the mid lesion is for sure severe.
Okay.
And after that, we have to measure the severity, the area of the ostial intermedius branch. So this is a small vessel. Go proximal to the right, or proximal. probably when you see the structure, okay,
Okay.
probably there you can measure a line to see the reference diameter. Okay. 2.25, 2.5, okay.
Okay.
And now the proximal one. This is the lesion, okay. Proximal, 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 proximal. Okay, there.
Okay.
Some calcification, but not too heavy. 2 point something. I think that with a 2.25 or a 2.5, this is the decision. Probably this is more proximal, that we are not going to land there. Okay, and now we are going to evaluate the proximal, the ostium. The ostium. Okay, there, an area, please. We have administered nitroglycerin, but after crossing the wire, we have again a vasospasm. It's similar than the LAD. We have a clear disease there, but a 4 point something probably is less than 4.6. It's a more disease vessel right just distal to this frame, but 4 point something I think is more elegant, smart, is more beneficial for the patient to treat only the focal lesion at the mid part and then leave the ostial part, just not treating the left main, because probably there is no need now. Tenemos un balón de 2,5 por 12. Vale, pues dame el de 2,5, 12. We're going to use the initial balloon of 2.5 by 12 that we used before for the LAD. We're going to be cautious with the dilatation because the lumen is near 2.5. Vamos, que tú me has dado. Sí. ¿Tienes? Ok. Tengo la guía. Let's see if the balloon crossed well, because it has been. I feel some friction here. Okay. This. Okay. 8, ¿vale? 8. Okay, down. Veamos la carátula. Okay. We have inflated at 8 atmospheres test. Look the spasm. It's amazing the spasm that the patient does after crossing with the devices. So we are treating this. We are putting nitroglycerin and measure again the ostial part. Okay. Dame nitro, por favor. We're going to administer some nitroglycerin. Contrast. Venga, preparada. Fine. Okay. Bueno, we can use a synergy of 2.25 by 18, something like that. 2.25, 15, 18. Sí, ¿el siguiente cuál es? No digo de longitud. No, de más que 16. We are searching. 20. El balón era 12. Dame el 16. We are using, as I think the best landing zone distally is a little bit farther the critical lesion. I'm going to use a smaller stent at 2.25 because the luminal area was between 2.2 and 2.5, and then analyze with IVUS if we need to post-dilate the proximal part. So we are using a synergy stent 2.25 by 16. I think the expansion of the balloon was good. There is no a severe calcification in the IVUS, so let's trust in the synergy stent to achieve a correct expansion. Tengo yo. Cuida la vía. No te preocupes, luego lo vemos. Okay, let's go with the stent. Okay, it crossed perfectly. Test, please. I'm going to advance a little bit. I'm going to check the initial angio. Okay, the lesion is there. Okay. Test, please. Vale, ábrelo ahí. A 12. Okay. Quite good expansion. Baja. In angio. No question, right, Borja?
No. No question.
Test pequeñín. Okay. Now everything seems worse because the stent is quite good. This is the best part of the vessel right now. We're going to administer nitroglycerin again and check with IVUS. Okay, nitro. So today, both cases for midstream are two interesting cases regarding research, because this is a multivessel talent patient, and we are trying to include in the second case of today a patient in the vulnerable trial that is directed by our friends Josep Gómez Lara and Enrique Gutiérrez and promoted by EPIC. Okay. Dame un pequeño test, por favor. Vale. Ok, vamos a hacer un cine después IVUS, ¿vale? We're going to do a cine with nitro and then doing IVUS. Cine. The proximal part is difficult to analyze. Let's do IVUS. I think the stent is quite good, and we have to decide what to do at the ostial part. Probably we have 2 to 4 millimeters healthy. We can check in the IVUS. Borja, can you put the IVUS of the initial IVUS of the intermedius branch? We're going to check now again, but the ostium. Can you do several measures at distal different parts of the ostium? Go frame by frame with the yes. My doubt, Borja, is if we have enough space at the ostium to implant a stent without entering in the left main. It's difficult. I think there is plaque all the way down. Okay, let's check with IVUS again. IVUS live, please. and this side. Another option is to try with a drug-eluting balloon here. Okay, there, perfect. Flash, okay, pull back. This is the distal, very distal part, the stent, very well opposed. And the proximal part is okay, and let's see the ostium again. Probably we have a couple of millimeters there.
Yeah.
Okay, Borja, can you measure again an area at the ostium? Frame by frame, go frame by frame. No, go back, go proximal when you see the wire in the LAD, and then frame by frame, distally, and when you see the circle in the, when you lose the wire at the LAD, you measure, there. I think the ostium is more or less healthy. Okay. It's in the limit. Okay. Go frame by frame distal, porfa.
Okay.
Please. Sigue. The vessel is not too big. It's quite severe here. Okay. Dame el balón de 2,5, por favor. We're going to dilate. The stent is okay, so I think we don't need to post dilate it, and we are going to dilate the proximal part. Is not the ostium. Okay, there. ¿Me buscáis un balón de fármaco de 2,5? 20 creo que hay uno. Sí, vamos a predotar. So my idea is to dilate this proximal part, being sure to not enter in the left main, and then try with a drug-eluting balloon, because we have only a couple of millimeters of a healthy or less diseased zone near the ostium. So if the result is okay with a drug-eluting, okay, balloon probably is a good idea. And if not, I think we have enough space to put an stent. Okay, this. This. Okay, venga, quédate ahí. Sí. 14. Ok, baja. This. Ok, vale. Vamos con el balón de fármaco. Okay, let's go with the drug-eluting balloon. It's difficult to analyze the results, the areas in the IVUS, because I think the wires are producing vasospasm all the time. So you need to analyze the real area without the wire, but it's impossible to do the IVUS without the wire. So sometimes this is a difficult part. So let's try with the drug-eluting balloon. This is a magic touch, a sirolimus eluting balloon. 2.5 by 20 to be conservative with the a little bit bigger than the distal part, but I don't want to dissect proximally, so we are using this one. Tengo. It's quite important to be not in the ostium but 1 millimeter distal. we have only this length, 20 in the 2.5 size, so probably we are entering, probably not, for sure we are entering in the stent. This. Okay. This. Ok, vale. Infla 6. 6. Vale. Vamos a aguantar ahí. Un minutito. We are waiting. I think we are there. The expansion is quite good. We are looking for the ECG and also the blood pressure. Patient is tolerating quite good. The ECG is normal, and before with the vasospasm, the ST segment went up a lot, so I think we are not occluding the LED. Okay. And 1 minute, go down. Let's see. Test, please. Not bad. As we have commented in previous cases with the drug-eluting balloon, we have to learn to be comfortable with these dissections that are not flow limiting. Okay, there. Okay, I'm a nitro. We're going to administer nitroglycerin again. Perform an angio and then the final IVUS. Okay. Vale. Cine. Look, there is some dissection at the proximal part, but it's a A or B dissection without impairment of the flow. The Austin of the lady is the same. So I think we can do a final IVUS in the intermediate branch and finish the case for today. We have used 180 IVUS. 180 cc's of contrast. And I think this is enough for today. We are going to follow the patient in the outpatient's clinic, and if he has some symptoms, we can go for treatment of the right and also for this chronic total occlusion of the circ. I think we can finish after this IVUS. Vengo. Okay. Here distal to the stem. Oh, calambre, live. Okay, this is the distal vessel. Some disease here, very distal. The stent is quite good. I think that we haven't dilated with the drug-eluting balloon here, probably in the proximal part of the stent. The stent is quite good. Let's see, probably we can see the dissections of the proximal part at some point. Probably there. Okay, okay, very good result. Okay, let's stop the pullback, and we are not going to inject anymore. because of the small dissection we have. We have the final angio that I am going to show you again. Okay, fuera. So this is the final angio of the intermedius branch. The stent is quite good. We have the dissection at the proximal part, but with the drug-eluting balloon. It's a very good result in my opinion. This moderate lesion at the ostium of the LAD that we have decided to be conservative today. And the final, this is the caudal view and the final result of the LAD. That is, I will show you. I know where is the cine, but we have checked with the IVUS and it's quite good. Okay, let's do another one in the coronary view because I don't know if we have done it. Very slowly. Okay. I think we can retrieve this wire here, this one here. Dame más nitro, por favor. Un poquito. More nitroglycerin. If we have to do another one, probably it's better to administer more. Blood pressure is quite good. Okay. Contraste. Okay. Let's wait some seconds. You are seeing with this diffuse disease that the best portions of the vessels are the portions we have treated. Okay, Parada. Cine. Yeah, very good. Okay, so I think we have finished the case. I'm going to retrieve everything and see you in the next case at 2 p.m. Madrid time. See you. Ya está. Bueno, no me lo han dicho, pero la guía, 035. Okay, we have a stop recording.